I'm very happy to present and have to disclose that we were supported by Medtronic for the implants of that following study and the travel grant. As reported before, and this is the major difference, usually with a spinal cord injury, we do know that after a complete spinal cord injury, DSD is the outcome depending on the level. And I talked already about the options we do have. So far, single cases of sacral nerve modulation have been not really successful because usually it was an approach of a unilateral side. The study setting, different to what I reported before, it's a very early sacral nerve modulation with the hope to avoid DSD. Since 2005, almost at the same time when we started with the other patients, we asked 10 patients to be involved into this study. They had their lesion above TH10 and they were proven to be ASIA A. The inclusion criteria was that we were not able to detect any detrusor overactivity by the time we performed the first urodynamics. 6 patients in addition who declined to participate became the control. We performed the surgery because of the injury and local anesthesia to be sure that there is no discomfort. The patients received a bilateral electrode connected to an InterStim II, which was new at that time, and the follow-up was every 3 months in the beginning, later on every half year. This is the urodynamic findings you have with an atonic bladder, not investigated at that time, the sphincteric area. The surgery was performed in the way with a PNE in the beginning, and different to many other patients who have an EOAB, the reaction in the anus was quite strong because of the nerve innervation. Then place the electrodes bilaterally on S3 or on the place best outcome, connected to the InterStim II, which is small enough to be placed in the buttock and not to be concerned that it might cause atrophy or even perforation in the long term because those patients will be in a wheelchair. The outcomes which have been already published are more or less 2 years. In the clinical view, the most important thing is that those patients did not need any other drugs, either antimuscarinics or botulinum toxin, and the average bladder infection within the time frame of 2 years was 0.5. The bowel movement was supported with suppositoria. Urodynamic findings confirmed that the bladder was still more or less atonic, with an average filling around 400. In the diaries of those patients, we found an average filling of almost 600 mils. Some of the patients, because most of them are male, were able to have erection with intercourse regarding to the programming. Those patients who did not or had the situation of a dislocation, we performed a new implant. That happened in some of the patients. The majority probably happened because of the overactivity of the lower limb. Untreated patient, as expected, developed a DSD, which was treated in the long term either with antimuscarinics or botulinum toxin. Their outcome, almost the same time frame. We started a little bit earlier because there were concerns of the first patients to participate, but they had more urinary infections, which calmed down after those 2 years. And as expected, their bladder filling capacity was around 200, and in their diaries they reported almost 300 mils, but they had much higher situation of incontinence. If an electrode needed to be replaced or repositioned, we were able to reverse the contractility of the detrusor, as here as an example, the atonic bladder, and here after reversing the situation. As stated for those patients with a follow-up after 2 years, now the date statement over 70 months, 75 months is almost 6 years. We were able to confirm for 5 out of that 10 patients the similar outcome urodynamic-wise. They were still able to have intercourse with the programming, and we confirmed that their bladder atonic situation and filling was the same. In conclusion, even after 6 years in 50% of those patients with an early sacral nerve modulation, we are able to prevent detrusor sphincter dyssynergia. We are able to improve their bowel movement. Some of them had good erections for sexual intercourse, which improves their quality of life. But still, this is needed to be proven in a multi-center study. Thank you very much.
Open for questions. I have a question for you. You have about 50% dropouts. This dropout, you can consider negative results?
Well, the dropout situation is definitely a way of concern. Those patients are not only dropout. Some of these patients, when they were involved, have been in the army at that time, issues of drinking, so some of these patients are not so easy to follow up. And one of the major backdraws of this study is if the electrode is dislocated and they don't see or feel that they have a problem, usually urologists think it is an infection and treat them. And if that is taken for too long, these patients are coming already with a DSD situation, and even the reprogramming or replacing the electrode does not help. So that's a further concern.
Sorry, can you remind us why it's bilateral rather than unilateral?
Absolutely. If one electrode is dislocated or ruptured, it does not work any longer. I think it is a very important information we learned out of it. Momentarily, we definitely need a bilateral implant.
Please.
From Innsbruck, Austria. I would like to congratulate you to having taken the initiative to do such a study. However, you mentioned during your talk the patient's detrusor function was more or less atonic. What do you mean by that? And in the conclusions, you did not mention the detrusor contraction. Could you explain this a little bit in more details?
Yes. Well, I only had one of the examples. If the bladder pressure on the filling, and as you have seen, the filling was done with 50 mils per minute, which is more or less for idiopathic the best way, but because we knew that these patients have quite a good bladder capacity, the bladder contraction was not seen as usually on those patients who are just receiving antimuscarinics or botulinum toxin. So to declare those patients as really atonic is very difficult as soon as you see an increase of the bladder pressure during the time of filling, and we fill usually up to 500 mils.
Yes.
Sakaki Baru from Japan. Thank you very much for your presentation. I have one question for you about the bowels. And after the procedure, the patients did not develop the anismus, you mean?
I'm sorry, I might have not catch it because of the echo.
You said the patients are preserved their bowel function. What I ask concerns about is this development of anismus?
Well, a lot of the patients are usually taking oral laxatives to be able to have bowel movements. These patients only needed suppositoria, so they had a much better control of their bowel movement, and they did not repeat or report about the situation that they had unwanted loss of stool, which can happen also. On the other side, it is very difficult to really discriminate, because if a patient receives antimuscarinics, they are obstipated. If a patient is just under electrostimulation, he does not have this effect. So we do know already from the colorectal surgeons with the neuromodulation there is a better bowel movement because of the stimulation. So we cannot discriminate between, on the one side, antimuscarinics, and on the other side with neuromodulation, which is also improving the bowel movement.
Could I ask one more thing? And have you measured before and after the procedure, such as the colonic transit time or etc.?
Well, you cannot differentiate that because these patients are receiving their implants within 3 to 6 months after injury. So you do not have the option to compare that before and after. It is definitely a question, and this is one of the major points of discussion, when to start. We have seen other patients because they pushed, they wanted this implant, and they already had a certain overactivity. Then it does not work. It progresses much faster, and those patients need in the long term, within a year, antimuscarinics or Botox, and then the effect is not as wanted. So we probably have only a very small frame where we can implant, but we cannot compare before and after, and we have no chance with this knowledge momentarily to give the patient the option, or for us as academic knowledge wants to grow, to do a sham operation or even switch it off, because we know when we switch it off, it causes the effect.
Thank you.
Please.
Yeah, hi, Mike Gralnick from the United States. So you went straight to a full implant. There was no test phase that we normally do with InterStim. Is that correct?
Absolutely, because what do you want to do in the test phase? This patient is in the beginning atonic, and then you cannot make the decision on that. You see right away in the surgery that he does have a good anal contraction, so you know that you're in the right place, but you cannot differentiate that you would wait.
Please, last question.
Emmanuel Chartier from Paris. Congratulations for your work. I'm there. And we are all very happy to have long-term results on your study. I have a question regarding electrode placement. How do you select the placement regarding S3 or S4? As I understand, you just have an anal contraction to select the positioning. And then what do you mean by electrode repositioning, as you spoke about that?
Yes. Well, these are several questions.
Yes.
Positioning just in this common way as done all the times when we do a sacral nerve modulation with the best response to the anus. Probably that could be further improved with the St. Mark's electrode and those findings. Second, repositioning of electrodes works in the same way as if it is a new situation. Usually, and I've shown you 2 slides, one where the electrode was ruptured, so it needs to be removed, and a new one placed in the same fashion as done on the video. Or if it is possible to reprogram them, we try to reprogram. We found that depending to the X-ray, sometimes it's only a slight movement, and these electrodes, the tine lead electrodes, have more the tendency to move inwards because of their tines than outwards. And that is changing a very small window of the high selective, because the amplitude we are using is 0.7 on all patients. All patients receive the same parameters.
Okay, thank you very much.
Thank you very much for this opportunity.